Good morning. In this presentation, we're going to discuss how to fight diabetes. According to the estimate of International Diabetes Federation, 1 in every 11 adults of the global population has diabetes, with an overall disease prevalence of 425 million. This diabetes prevalence is expected to increase exponentially with time because of the global obesity epidemic related to physical inactivity and adverse food habit. Therefore, diabetes and other physician and other healthcare provider face the challenge of managing diabetic patients in their day-to-day clinical practice and are expected to have adequate knowledge and skills of dealing with this case. Optimal management of diabetes primarily target adequate control of plasma glucose level in the normal physiological reference range, as in healthy non-diabetic subjects, without causing risk of hypoglycemia, meaning low blood sugar. Normal plasma glucose level in healthy individual depends on the dietary intake of a nutrient, physical activity, hormones that control glucose sugar homeostasis, especially insulin. Therefore, diabetes management should target first and foremost dietary intervention, modification, and lifestyle, including physical activity, hormonal manipulation, mainly insulin, and its or other effect. This presentation gives an overview on the type of non-pharmacological intervention of the effective management of patients with diabetes. When we say non-pharmacological, means no medication. The risk of type 2 diabetes rises steadily with increasing body weight, and those with morbid obesity have a higher risk of disease. Excess body weight related to physical activity and over-nutrition results in the accumulation of fat, mainly in the abdomen and the visceral tissue. This abdominal and visceral adiposity in turn modulate several hormones and chemical mediator in the body that results in diabesity, the term coined the interlink between diabetes and obesity. The metabolically obese phenotype, having normal body weight and normal or low body mass index, but increased abdominal obesity, is another underestimated risk for the development of type 2 diabetes. Free fatty acid derived from visceral adipose tissue reduces insulin sensitivity and impair the beta cell function, resulting in lipotoxicity and result in the development of diabetes type 2. In type 1, there is absolute insulin deficiency, and therefore management is mainly with insulin. However, the treatment of type 1 also considers dietary modification and physical activity for optimal outcome. Obesity affects the proportion of patients with type 1 diabetes that resulting in increasing their insulin requirement and adverse effect on their metabolic control. Therefore, lifestyle modification are important even in the case of type 1. Although bariatric surgery are usually done in patients with type 2, obese patients with type 1 also have shown to be benefited from the bariatric surgery with significant reduction in insulin requirement and modest improvement in diabetes control. We have the medical nutrition therapy, and this is the crux of the matter. The American Association of Diabetes uses term medical nutrition therapy to describe optimal coordination of dietary intake with diabetic therapy, both pharmacological and non-pharmacological, to achieve a favorable outcome. MNT can be used in primary, secondary, and tertiary prevention of diabetes type 2. The primary prevention measure MNT by modifying diet in high-risk individuals, those with pre-diabetes and obesity, to delay or prevent development of type 2 diabetes. The secondary prevention measure aim to achieve tight glycemic control by dietary modification and thereby reducing diabetes complication in patients with type 2. The tertiary prevention measures manage related complications such as cardiovascular renal disease in those with type 2 diabetes. The MINT not only aim at controlling blood sugar, but also improve other comorbidities such as hypertension, dyslipidemia, meaning high cholesterol, obesity. Diet with lower glycemic index reduces postprandial glucose, meaning the blood level after eating, excursion that improve the glycemic control. Non-nutritive sweetener, low-calorie diet may also help management of diabetes. Increasing intake of dietary fiber also improve glycemic control. Routine supplementation of vitamins and antioxidant trace minerals are not recommended unless there is a deficiency. Hypocaloric and low-carb diet help weight management, along with metabolic control in type 2 diabetes. People with pre-diabetes and diabetes should receive individualized mint from registered dietitian familiar with the diabetes. Steps involved in mint planning and implementation are given in many health benefit of Mediterranean diet. This is a very important issue here, as Mediterranean is the countries around the Mediterranean area. And the health benefit is of that the Mediterranean diet is based on plant, which is known for various health benefits, mainly cardiovascular and cancer. MD has favorable effect in people with diabetes. This dietary pattern adapted in the olive growing area of Mediterranean region, especially Greece and Italy, in the late 50s and 60s, collectively known as Mediterranean, is used to describe traditionally followed dietary pattern of people living in this country. This type of diet uses high amount of olive oil, vegetable, legumes, whole grain, fruit and nuts, moderate amount of poultry, fish, and low amount of whole fat, dairy product, and red meat, and low amount to moderate wine. The Mediterranean diet is found to be protective not only in healthy individuals, but also in women with a history of gestational diabetes and those with cardiovascular disease. In the non-diabetic participant with high cardiovascular risk, Mediterranean diet was found to reduce the incidence of type 2 diabetes by 52%. In patients with type 2 diabetes, Mediterranean diet is found to be beneficial in glycemic control and in reducing insulin resistance. The health benefit of Mediterranean diet in diabetes is basically plant-based, and it's known for various health benefits in reducing development of diabetes. Dietary intervention in diabetes type 1. Although the principle of mint are similar to the management of diabetes type 1, another important aspect of dietary management is considered in these patients with type 1. Insulin dose can be calculated as per carbohydrate counting principle, adopted for patients to optimize glycemic control. Carbohydrate counting is a method of calculating grams of carbohydrate consumed in a meal expressed as a gram or as a serving. One carbohydrate serving is equal to 15 grams of carbohydrate. Calculating the insulin to carbohydrate ratio helps in adjusting the meal time of insulin. Significantly better hemoglobin A1C reduction has been reported with this strategy recent meta-analysis. Therefore, in an ideal situation, carbohydrate counting should be recommended to all patients with type 1. This approach also benefits patients at risk of hypoglycemia because of appropriate insulin dosing as per patient's metabolic requirement, and food intake help to prevent hypoglycemia, i.e. low blood sugar. There are physiological changes during exercise. During the first few minutes of exercise, the glycogen is broken down and used. But with continued exercises, muscle glycogen break down and decrease and fall in the blood sugar results in suppression of insulin production and increase the glucagon secretion. This is another hormone that is in charge of metabolizing sugar, which stimulates hepatic glycogenesis. With the prolonged exercise, muscle glycogen store get depleted and free fatty acid derived from breakdown of triglyceride are used as fuel for muscle activity. Exercise increases glucose uptake and the use by skeletal muscle by increased translocation and expression of glucose transporter GLUT4, an isoform of glucose transporter from intracellular storage depot to plasma membrane by increasing insulin sensitivity. Exercise also improves hepatic insulin sensitivity, reduces insulin resistance, improves blood glucose disposal to the peripheral tissue. You don't need to bother yourself with these details. The whole issue is about exercise help to improve the control of type 1 diabetes. In type 2, a patient with type 2 should engage in moderate to high-intensity exercise for at least 150 minutes per week, spread over minimum 3 days a week. They should have no more than 2 consecutive days without activity, or 75 minutes per week of intense, vigorous physical activity. Adults should also perform muscle strengthening exercise involving all major muscle groups for 2 or more days in the week. All individuals should avoid prolonged sitting and sedentary activity by breaking every 30 minutes with a brief standing, walking, or performing other activity. Frequency, duration, intensity, type of exercise program, age of the patient, and adherence to the exercise program are the major factors influencing the benefit of exercise therapy in type 2 diabetes. I hope this statement would be an encouragement to every patient with diabetes to stand up and walk or run. It was found that exercise-induced improvement in insulin sensitivity lasts between 24 to 72 hours, and hence, type 2 diabetes patients should perform regular exercises with no more than 2 consecutive days without physical activity to maintain the benefit. The beneficial effects are also show clear linear relationship with total energy expenditure during exercise. The relative risk of development of type 2 diabetes in men who exercises once a week only has a higher than those who exercise more frequently. Physical activity in type 1, exercise training in the form of resistance, endurance, combining training consists of both, has been shown to improve glycemic control and better improvement of type 1 diabetes. We need to keep in mind that there is substantial risk of hypoglycemia during the exercise and after it. At the time, post-exercise hypoglycemia, meaning lowering of blood sugar, is encouraged in patients with type 1 because of the surge of counter-regulatory hormone during and after exercise. Insulin treatment may need modification in patients who do occasional unaccustomed activity to prevent these complications. Bariatric surgery. Various surgical procedures, collectively named bariatric or metabolic surgery, initially proposed for the treatment of morbid obesity, are also found to be effective in both the prevention and control of type 2. It is interesting to note that this procedure can even result in remission of type 2 diabetes. The restriction in calories intake achieved directly by surgical procedure and indirectly by self-adaptation to restrict postprandial dumping syndrome, alteration in satiety by postprandial neurohumoral signal and incretin effect, malabsorption of nutrient, and increased beta cell mass, and improvement in insulin production and changes in the gut microbiome are some of the mechanisms that play an important role in control and remission of type 2 diabetes in patients that are going bariatric surgery. Now we come to something that is very interesting, that poor sleep hygiene affects diabetes control. Sleep is a restorative process for both mind and body. There are 5 stages in sleep: non-rapid eye movement sleep, stage 1 and 4, rapid eye movement sleep. Of these, the deeper stage of non-rapid eye movement, it is stage 3 and 4, also called slow wave sleep, and also it is most restorative. Proper sleep is important for a normal diabetes control and hormonal regulation. Sleep deprivation and poor quality of sleep results in altered metabolic and hormonal function, leading to development of diabetes too. People who sleep less than 6 hours per night are at risk of developing diabetes. It is advised to have at least 7 hours uninterrupted sleep per night. During sleep deprivation, brain glucose is reduced and there is hormonal dysregulation, resulting in overall higher growth hormone and even in cortisol level that may contribute to the development of diabetes type 2. Increased sympathetic activity, reduced parasympathetic activity, and increased level of inflammatory marker in these cases may play a role in development of diabetes. Sleep deprivation results in weight gain and obesity by multiple mechanisms, such as hyperactivity of the orexin system, overeating, and reduced energy expenditure. In conclusion, there are multiple pharmacological treatment options in patient diabetes 2. The non-pharmacological intervention will always be considered as the main and the most important. Appropriate dietary intervention coupled with regular physical activity are extremely important in management of type 2 diabetes to obtain and improve glycemic outcome, but also benefit of control of other problems like dyslipidemia, hypertension, obstructive sleep apnea, cardiovascular disease. These interventions are also beneficial for patients with type 1. Now this comes to bring us to the conclusion of this presentation. I hope out of this presentation to stress the fact that dietary control, modifying lifestyle activity, stop smoking, exercise regularly, help a great deal in controlling diabetes, and it might be the only treatment required to prevent diabetes and improvement in control of sugar in the body without having to resort to medication or insulin. I hope you enjoyed this presentation as much as I enjoyed preparing it. Thank you.